병이지. 나구나. 나까지 카운팅을 해, 바보야.
왜 그래요?
어, 비디오 시작하는 게 낫잖아.
들리세요?
네, 들립니다,
예,
원장님.
예. 그러면 잠깐만요.
네.
제가 그걸 설정만 잠깐 할게요. 잠시만 기다리세요. 이게 키펀텀 오케이 됐고. 팀장님 질문 너무 이상하면 알아서 좀 걸러주세요.
아니, 원장님, 저희 지금 본 웨비나 링크가 개설돼서 참석자가 8분이.
아, 그래요?
네.
아니 근데 이제 조금 이렇게 정리하셔가지고 뭐
네.
벌써 대답했거나 아니면 반복되는 그런 거 있으면
네.
가끔 이렇게 중복되는 거 그런 거 조금 있어요.
네.
그래서 그런 거 조금 잘
네.
정리해 주세요.
네, 알겠습니다.
그리고 45분부터 연다고 하지 않았어요?
그 본 링크를 45분부터 열려면 테스트가
음,
진행을 할 수가 없어요, 원장님. 그러니까 지금 저희 그 화면 맞추는 거를 다시 한번 또
음,
하셔야 돼요.
아,
본, 네.
그래요?
그러니까 링크가 개설될 때마다 계속 하시는 거라고 생각하시면 될 것 같아요.
지금 제 스크린 보이시죠?
스크린은 보이는데 예, 지금 잘 보입니다.
지금 풀 화면으로 나오나요?
네, 잘 보입니다.
그러면
제가 토론 들어가야 될 것 같아요.
이거 하나씩 다 들어가야 되나? 맨 처음으로 못 들어가나? 오케이. 첫 화면 보이시나요?
네.
네, 보입니다.
오케이. 껐어요. 쉐어를.
네.
그리고 그러면 카톡 한번 테스팅 해 보실래요? 그쪽에서. 그러면 Q&A 창은 밑에 있나요? 저는 안 보이거든요. Q&A 창.
그 화면 쪽에 아래 그
음,
마우스를 내시면
음,
참가자랑 Q&A 설문조사 채팅 등이 있어요, 원장님.
아, 이거
화면이면
좀
그,
크게 해야지 나오는군요. 네.
네,
올리브 킴 누구시죠?
접니다.
아, 네. 돈가스. 한번 테스팅 하실래요? 아니면 안 하셔도 돼요?
그 Q&A 화면만 잠깐 보여드릴게요, 원장님. 어떻게 진행하는지만 사전에
네.
네.
음, 음.
음. 저희가 이렇게 퀘스천 박스 만들고 원장님께 계속 하나씩 질문을 드릴 거고요. 거기에 대해서 답변 주시면 될 것 같습니다, 원장님.
지금 참석자들이 있으니까 카톡으로
네,
저기
알겠습니다.
전화할게요.
그럼
일단은
네, 일단 대기.
공유하면
네.
잠깐만요. Stop sharing. 제가 한 번만 다시 잠깐만요. 그 줌이 또 없어졌다.
소리.
지금 뭐 공유하셨죠?
네.
네.
어, 잠깐만요. 그거를
원장님께서 공유하시면 제게 바로 중지되거든요. 그냥 공유해 주시면 될 것 같아요.
음, 화면을 끄셔도 될 것 같아요. 지금 팀장님하고 서인 씨,
네.
예, 제가 잠깐 이거 조절을 좀 해볼게요. 이게 자꾸 창이 뒤로 가가지고 조금만 시간 주세요. 팀장님 들리세요?
네, 들립니다, 원장님.
혹시 화면 잘 보이시나요?
네, 화면 풀스크린으로 잘 보입니다.
지금은 되는 것 같아요.
아, 됩니까?
그리고 제 카메라도 보이고요.
네, 잘 보입니다, 원장님.
음, 레이저 포인터 보이고요.
네, 보입니다.
오케이. 그러면 스톱 쉐어 할게요.
네,
그리고 저 카톡으로 통화할게요.
알겠습니다.
네.
Hello, everyone. Thank you for joining JACE's Online Academy. Today, we invited our KOL, Dr. Michael Kim from Aeon Medical and Aesthetic Center in Singapore as our speaker. Dr. Kim will share his knowledge on HIFU treatments utilizing dot and linear cartridges of Ultrasound Q+. If you have any questions during the webinar, please leave your questions in the Q&A box. Dr. Kim will answer your questions during the Q&A session. Thank you.
Hello, everyone. I hope everyone is doing okay. My name is Michael Kim, and I'm based here in Singapore. Can you hear me, everyone? Is it okay? Jesus?
Yeah, we can hear you.
Okay, good. Let me, get the share screen working here. Okay, can you also see my screen now? Full screen?
Yes.
Okay, good. All right, so thank you everyone for joining today. You know, I know everyone must be busy. This is a global event, so people are in different time zones. I just want to say thank you for taking precious time out of your day to join me today. I want to thank JACES for the opportunity to share today on ultrasound properties and combination dot and linear HIFU. This is one of my favorite topics and one of my favorite treatments, and I'm very excited to share with you today. And usually I'm very rushed for time and I speak very fast. And today, JACES has been very kind to let me, share everything that I can. And, it might be, the last presentation for a while with the end of the year coming up and everything. So, I hope to share with you everything that I've learned and things that I've been thinking about and learned, and hope that it will help you in your practice that we share today. So without further ado, let's start. Okay, sorry. Okay, I have no conflict of interest to disclose. So if you know, you know, Squid Game has been so popular worldwide. And so if you've seen the drama on Netflix, you probably know what this is. But today, we're not going to be talking about Squid Game. We're going to be talking about HIFU. So just to introduce myself, I was born in the US. That's why I have an accent, an American accent. We say that we don't have accents, but some people do. So our family moved to Korea. I'm Korean, and that's where I went to medical school. And then I moved my family to Singapore, where I've been living now for the last 14 years. And I know that each of us, in our own countries are dealing with a different situation when it comes to the COVID pandemic. We're all in different emotional and financial circumstances. Even here in Singapore, we've been having a very high rise of cases, more than 2,000, which is a record, even though we have above 80% full vaccination rate. So let me just say that my prayers are with all of you, and let us keep strong and united. And we're all adjusting to the new normal, which for many of us requires a lot of adjustment. Same for us and for our patients. Some for the better and some for the worse. I just wanted to share a few emerging trends of a COVID area in aesthetic medicine, mainly from a patient's point of view. I think that for a lot of patients, there's more time. People are not traveling more than as much as before. So they have more time and budget to invest in themselves. Secondly, there's more emphasis on safety. With the virus going around and always constantly thinking about our health, patients are thinking about what can I do that's safe, that requires less visits to the clinic, with less contact with the treatment provider, less side effects. And they also have more time to study. They have more time to scrutinize treatments. So from our point of view, we need to have a deeper understanding of what treatments are, how they can help the patients. And I think there's also more acceptance of downtime. Now that a lot of people are wearing masks and working from home, there's more acceptance of downtime. And when it comes to fillers, there are some concerns about filler complications after COVID infection or COVID vaccination. This is another topic that I spoke on previously. If you're interested or you have some cases, you can DM me or contact me. We can discuss this. And I think that patients now are seeking more fundamental skin improvement treatments. I think there has a change in the mindset of many people and many patients, and they're looking for something more basic, more fundamental in their treatment regimen. And due to the COVID pandemic, all healthcare professionals have been pushed to the forefront of the public's eye, and aesthetic doctors are not exempt. I think we should, look back and reflect on our profession now as healthcare providers, as doctors, now that we've been through so much. And is there a paradigm shift that we need to undergo? I've always started off my presentations with talking about paradigm shifts for the last few years. To be more accurate, the need for a paradigm shift in aesthetic medicine. Now, paradigm shifts always begin as a minority when they start, and sometimes it gains traction and it becomes a majority and eventually the new normal. If it does not gain traction and support, then it will become obsolete in the macro scheme of things. And the reason I'm bringing this up in a HIFU lecture is because I think without this paradigm shift, without this change of our mindset, we cannot fully appreciate what HIFU is. I really think that HIFU is a treatment. It's not whether I should get a HIFU machine or not. It's really, I think all aesthetic doctors should have a HIFU machine, and it's just a matter of which HIFU machine and how we're going to utilize it. How do we use it in our approach to treatment of our patients? That's the questions I think that we need to be looking at, and to approach that and to achieve that, we have to have a paradigm shift. And the challenge I feel we have now in aesthetic medicine is how to provide safe and effective treatments that provide long-term natural skin quality improvements. We should be rethinking our approach to our patients when they come to see us for their concerns, and by giving more attention to their skin quality and skin health. It might lead to a change. Of course, at this juncture, having new technology and treatments are crucial to advancement. And from here, it will eventually lead to a divergence from the way we have previously approached our patients. And if this becomes mainstream, the small divergence will evolve and become the new normal, completing the shift of our paradigm. And treatments like HIFU are at our disposal to help improve patients' skin quality and improve their skin health. But if we're not interested in these type of goals, it will be very hard to become more investigative and active in utilizing these treatments in our practices. But I think if you're attending right now, I think you're already aware of the challenge and have already started to rethink and change your approach to aesthetic patients. We're faced with an enormous challenge due to our culture and conditioning. Well known in our field, Dr. Shino and Dr. Fabi recently posted about dysmorphia. I strongly recommend you read their posts. And quoting from the Mayo Clinic website, body dysmorphic disorder is a mental health disorder in which you can't stop thinking about one or more perceived defects or flaws in your appearance, a flaw that appears minor or can't be seen by others. And we will have more and more patients come see us influenced by the false photoshopped images on social media. In our consultation rooms, what will we say to these patients when they come wanting to look more like a celebrity or an influencer? What treatments will we offer them? On a group level, how will we rethink and respond to this challenge? Are we feeding the fire in terms of pointing out flaws of patients and where they need fillers? For some patients, this might be what they want. As in the case of these celebrities, I'm sure they probably wanted treatments like this. But for others, it might not. This celebrity in China claimed he did not want to look like this after his treatments and blames the doctors. To the average person and the public, we as aesthetic doctors are responsible for these phenomena. We are commonly perceived as doctors who do not truly practice medicine. We are thought to feed on the vanity of patients like some type of predator, and our patients are downgraded to customers or clients. We need to rethink our position as aesthetic physicians and ask ourselves as a profession and a professional, what is my practice? What procedures am I providing? What type of aesthetic doctor am I? Conventional aesthetic practice has involved a substantial amount of fillers and toxin as the mainstay of treatments offered, which is not wrong, but it just has inherent limitations in regards to the extent it can help improve the patient's fundamental skin quality and skin health. It is not a simple matter of right or wrong, but about balance and appropriateness. Patients will ask our opinion and recommendations. What will we say? I think there are more evident changes recently. This year, a very excellent article in an attempt to standardize criteria for skin quality was published and was sponsored by a major industry player. I hope it can be a catalyst for more advancement in the area of skin quality research, and please read it if you have time. This article is already 3 years old, but was very instrumental in my approach to patients and striving for more natural results to improve the attractiveness of a patient. In this paper, it states that as we do more cosmetic procedures, we assume the patients will become more beautiful, but they continue to lose their genuineness also. We need to find that intersection where we achieve maximum beauty and attractiveness without losing the majority of what makes them unique and original. With this changing mindset of focusing more on skin health and skin quality, we are fortunate enough to now have many treatment modalities that are disposable to utilize in treating our patients. Using these modalities, we're able to provide safe, effective, and natural results to improve the attractiveness of patients without negatively altering their appearances. So this is the agenda for today. We're going to talk a little bit about basic anatomy, ultrasound, HIFU, dot and linear HIFU, some of the literature, but I won't go too deep into literature. You can take a screenshot and look up the paper and read it for yourself. That's really the best. Some clinical considerations, practical applications, and then there's going to be a video demo, which I go through how I plan and go through the treatment. And at the end, some few practical tips. So please stay till the end. So first, anatomy. And I'm not an expert in anatomy, and I'm not here to lecture you on anatomy. However, I want to challenge our approach and paradigm of anatomy. This is a slide we have all seen too many times. We're all taught that the face and the neck have distinct, separate planes. Some companies emphasize the absolute necessity to visualize or see the actual SMAS to put the energy exactly there. But in reality and in living tissue, we know that there are many more fibrous tissue connections which interlink each layer very closely. And all these connective fibers are involved in the elasticity of the face and neck, not just the SMAS. So let's take a look at the SMAS. We talk about it so much and the importance of visualization. This SMAS has been in debate for as old as I am, 45 years. That is how complex and complicated it is. In other words, there's no precise unified definition for SMAS. Look at all these definitions of what SMAS is defined as in the literature. In this chapter, in this book on SMAS, they analyzed 800 patients over 9 years. And these authors identified and classified the SMAS into 6 different subtypes. The writers actually called the SMAS the SMAFS, or SMAFS, the superficial musculoaponeurotic fatty system, which might be more anatomically correct, because in actuality, as you can see here in this electron microscope image of one type of SMAS, there are fat cells distributed in these layers. On the left is the fatty SMAS, and on the right is the fleshy SMAS. And you might be able to see the difference in fat content between the two, just as you might with marbling in beef. And they found out that the majority, or 80% of the SMAS, were membranous or fatty. They also determined that the variant of SMAS has an impact on the procedure and outcome of facelift surgery. So what about regarding the results of HIFU? Is this one of the reasons you might be getting inconsistent results, even though you might have visualized and treated the SMAS very accurately? So how much tightening and lifting is actually from hitting this layer with HIFU if 80% of patients have a thin membranous or a fatty SMAS? We also know that, we see results from HIFU too. Even though we might not visualize or we don't have the visualization, the real SMAS we need to conceptualize and target is a more complex architecture of fibrous tissue, which extends from the bone all the way to the skin. So recently, it's become more commonplace to acknowledge the presence of fiber structures extending from the periosteum through the SMAS into the subcutaneous layer and connecting to the dermis, thus forming a three-dimensional support network called retaining ligaments. And these locations are often thought to be in certain areas of the face only. However, this network of fibrous tissue may be more extensive than we think. Maybe it is more crucial and present in the whole face and body than we acknowledge. What if there's a more complex network of connective structure in living tissue, but we are overlooking it, using the convenience of distinct separate planes? This book can help you bring you outside the box, give you a new perspective on living tissue hierarchy. It changed my perspective completely. Not only does it challenge our traditional viewpoint and knowledge of tissue, it investigates living human tissue through a microendoscope to support its propositions. And let us all remember, it's living tissue that we are dealing with, not cadavers. In living tissue, this fibrous connective tissue runs through all the layers of the face and neck, and they are all important in our treatment approach. When these fibrous or fibrillar structures are intact, as you see on the top, the fibers are able to redistribute and adapt to the pull of gravity, maintaining balance and architecture of the ECM and cellular morphology. However, as we age, the fibrils become less resistant to tension and gravity, becoming less able to redistribute the forces, resulting in unbalance and changes in the cell structures enclosed in them, leading to micro changes of decreased cellular function and macroscopic sagging features of aging. This sagging phenomenon not only happens at a certain level like this mass, but at all levels, since the fibrous tissue runs through all the levels. So being able to tighten this fibrous tissue network at all levels is important to tighten, lift, and prevent further sagging of the face and neck. In actuality, this picture of the abdomen wall shows extensive fibrillar structures extending through the subcutaneous layer and are now the new target for abdominal rejuvenation. It is referred to as the fibroseptal network. Here you see the shrinkage of the fibroseptal network after RF treatment in the abdominal subcutaneous layer with vertical shortening and contraction in multiple planes, which led to tightening of the overlying skin. This fibroseptal network in the face may not be as large and obvious as in the abdomen, but is still there and contributes to various functions in living tissue. So is it subcutaneous fat with some small fibrous tissue, or is it fibrous tissue with some fat? And I think this is an important question because we're very set in our minds that it's epidermis, dermis, fat, muscle. But I propose that we have to look into the literature, look into what's there in living tissue, and that we don't call it subcutaneous fat, maybe subcutaneous layer, but focus on the fibrous tissue, which does have fat dispersed in between the fibrous layers. And if we acknowledge this, selective placements of the HIFU TCPs at the SMAS might become less relevant. Let's go on to ultrasound. First of all, ultrasound is a type of sound wave. And a sound wave basically is a longitudinal wave which causes particles in the medium it's passing through, whether it's air, water, or skin, to oscillate or vibrate in the same direction of the wave. Sound waves are made of compressions and rarefactions. Compression happens when the molecules are forced or pressed together. Rarefaction is just the opposite. It occurs when the molecules are given extra space and allowed to expand. And ultrasounds are sound waves with the frequency of more than 20 kilohertz. And from this amazing article from 2018 and the California Institute of Technology, if you have time, please read it. There you can it summarizes the three modes of ultrasound delivery. But as I did, many of you might be only familiar with the first mode, which produces heat. And this is actually from the pressure fluctuations, which leads to shearing motion of tissue and then eventually frictional heating. And this is usually the only type of energy that we discuss or learn about when talking about ultrasound or HIFU. However, there are two more types of energy we rarely talk about, and that's acoustic radiation force and acoustic cavitation. I'd like to talk a little bit more about this acoustic cavitation. So acoustic cavitation is basically when bubbles form from ultrasound energy. There are two types of acoustic cavitation, stable and inertial. And in stable cavitation, the bubbles oscillate or vibrate. And through this movement can impose different effects via microstreaming or physical action, while in inertial cavitation, the bubble will eventually rupture, releasing energy, sometimes in a fluid or air jet, which also impacts the surrounding environment, which we'll see later. So this shows the cavitation process and eventually leading to the fluid jet. And again, this can transfer energy to other areas around the bubble. There are other effects through ultrasound on the cells and ECM, and they include modulation of cellular membranes, stimulating cell function, stimulating the differentiation of fibrocytes into fibroblasts. Heat shock proteins are a family of proteins that are produced by cells in response to exposure to stressful conditions. So they're thought to be involved in very signal transduction processes, protecting the cell. So they're good, and we need them. And there are papers that show that ultrasound exposure can lead to increase in these heat shock proteins. And acoustic microstreaming can also modulate and stimulate the cell membranes. In this article from 2012, they showed that cells produce significantly more collagen and GAGs, or hyaluronic acid, after ultrasound exposure. And you can see that around the cells and dyed in this blue color. Just last April, a paper on ECM rigidity, which is closely related to how skin boosters like polynucleotides can affect, and its effect on sonoporation, focusing on the microbubble dynamics. And this was published. And on the left, you can see the different types of the interactions between the microbubbles and with their interaction with the cell membrane. And you can see how the substrate rigidity can influence the ultrasound bubble mechanics. Really opened up so many more possibilities when it comes to combination treatments. This different article on the therapeutic effect of ultrasound stated in the conclusion that understanding physical mechanisms are integral to clinical success, and that the fear of understanding cavitation and incomplete understanding of how to work with it has hindered further implementation of HIFU. The avoidance of cavitation effects on issue is probably why there's been little change or breakthrough in HIFU treatments, that is until now that we have linear HIFU available. The reason for me sharing you all of this is to convey that there's so much more than just the thermal heat from HIFU that is going on in the tissue. What have been the major breakthroughs in HIFU technology and HIFU clinical effects over the last few years? Patient expectations have grown exponentially, but our HIFU technology has been stagnant. There is more to HIFU energy, especially in the acoustic cavitation realm, but maybe we're just ignoring it because, well, it's very complicated and difficult to understand. Some may argue there's very little evidence published on the linear HIFU, which is true. However, the clinical potential that linear HIFU energy possesses through acoustic cavitation and nonlinear absorption are very substantial, in my opinion. Now, these are two books that some of the information that I just shared just now had come from, and I'm still studying them, and it's not easy. And I hope that we can study more together in this field to discover more breakthroughs for HIFU treatments in the future. Onto HIFU, we all know what HIFU is. So I'm just going to skip these slides. We've seen them many times. Now, there are two different types of HIFU energy delivery modes, but until now, we have only had the sequential or dot mode to use in our practice. Continuous scanning mode fires the energy in a predetermined trajectory. But as you can see here, as early as the 1980s, there were papers on this type of linear ultrasound energy. Here on the left is the dot type HIFU that we're all familiar with, and on the right is the linear type of HIFU. And actually, for some time, we've had this linear HIFU for body lipolysis, but as many will know, it's very painful. We needed to balance the effectiveness with the pain level and side effects. So this is a very important paper, very crucial paper that I feel forms the basis of understanding the two different types of HIFU energy and how they differ. For dot or sequential HIFU, we always get the question, how is dot HIFU different from linear HIFU? And it's really important to understand this paper to get to that question. And it's really the answer to that question. This is the x-axis here, while this is the z-axis. We're looking at it from above. In dot HIFU, as the interval space is decreased, the width increases and starts to overlap. And you can see that there's a fluctuation here in peak temperature. So this suggests more interaction between the points when the space becomes smaller. You can achieve smoother lesion boundaries by reducing the interval space, as you see here, but you will experience higher peak temperature and more fluctuation. In linear HIFU, this shows the difference in lesions when the speed increases. You can see the smooth boundaries along the scanning path reduced, and the fluctuations in the temperature profile are also reduced. And with a faster scanning speed, it's possible to achieve a lower temperature. So the article shows that with increased scanning speeds, the efficiency of the linear HIFU becomes higher with a lower peak temperature than dot HIFU. And interestingly enough, in the conclusion of this paper, they state that there's a need for better understanding of the relationship between heating and bubble dynamics, because it's just not explainable with just explaining using temperature or heat. There has to be something more going on, and they propose that it could probably be due to the bubble dynamics which are involved and are causing different results. And this is a repeating challenge from the experts. So our traditional concept of skin rejuvenation involves using thermal energy or heat energy, such as IPL, lasers, radio frequency, plasma. And we also included HIFU because there is also heat involved to stimulate collagen and elastin non-invasively. However, due to the thermal nature of these energies, those with darker skin types or more outdoor lifestyles may experience side effects such as PIH. In contrast, cold rejuvenation procedures can include modalities which use non-thermal mechanisms such as skin booster injections, LDM ultrasound, microdermabrasion such as hydrofacial, microneedling, and HIFU, due to its possessing both thermal and non-thermal properties, such as cavitations, which we just explained, can be classified as both. But its indications and applications, I feel, are closer to the cold rejuvenation methods, having the advantage of being suitable for all skin types and not dependent on sun exposure extent, which can be a large advantage to many regions in the world. Since this is non-thermal, the risk of pH is almost nil. Most importantly, cold rejuvenation modalities can improve skin health and skin quality by improving the ECM environment, increasing or replacing GAGs, therefore hydrating the skin, producing heat shock proteins, and regulating MMPs. So although both have their advantages, I feel with the increasing demand in darker skin patients and patients with more active outdoor lifestyles that we need more attention to cold skin rejuvenation. So onto dot and linear HIFU or Ultracell Q+. The name of the HIFU device, which has linear HIFU cartridges, is called Ultracell Q+. Linear firm refers to the treatment using the linear cartridges, or in Korea, they call it linear firm. And we'll pass this one. There are multiple cartridges for face and body treatments. The dot cartridges are called Q, and the linear cartridges are just called linear. And all the cartridges have beveled tips, and this makes visualization of the area being treated much easier, which is important for accurate and precise technique. The dot HIFU is the typical HIFU energy, which is used for tightening and lifting with temperature rising to 65 degrees, while the linear HIFU has a lower temperature of about 58 degrees, if you remember the paper, the article we just discussed, and can be used for bulk heating, fat lipolysis, and pigmentation, flushing reduction. Here you can see the pattern of TCPs in the phantom medium, and on the slide for dot and for linear. And going deeper into comparing the dot and linear HIFU, again, how is dot and linear HIFU different? This is a bit more complicated, but going into the physics of it, knowing that energy or joules is a function of power or watt and time. Let's assume that there's the same joule energy here, okay? So with the linear type HIFU, the thermal zone has a shorter on time, it's faster. So compared to the dot HIFU, which has a higher power watt energy, we can provide a higher power, which can provide better clinical results. And since the area is larger for the linear HIFU, it covers more area than the dot HIFU in total. Assuming again that the joule energy is the same, the fluence is relatively smaller, which can reduce the pain felt by the patient. So we can have better results, higher clinical efficacy, at the same time, less pain, which for those of you who have tried linear will know that it's less painful also compared to the dot at the same energy. Here you can see the actual difference in the area of the different HIFU due to their heat signatures. Dot on the left, linear, you can see it covers a larger area with a larger area heat signature. And we often talk about the difference between monopolar RF or thermage and HIFU as RF providing bulk heating and how it is more effective in skin tightening for superficial layers compared to HIFU, and is commonly used together to complement each other, like HIFU plus thermage. However, now with linear HIFU, this synergistic effect or this bulk heating can be achieved in one device because the bulk heating can be provided using the linear cartridges. Excuse me. For the linear cartridges, excuse me. excuse me, sorry for that. For the linear cartridges, we can see that 58 degrees and above is maintained for more than 2 seconds, which in turn provides lipolytic effects. This lipolytic effect is one of the major advantages of the linear cartridges, since more and more patients are looking to contour their face or neck non-invasively in a safe and effective method. We all know that cell death can occur above 56 degrees if maintained for more than 1 second, which can lead to lipolysis using the linear cartridges. Another advantage of the linear cartridges is less pain, and not only the linear cartridge, but also the dart cartridges with Ultrasound Q+. Pain with these cartridges are much less than the other HIFU devices. I've used 2 other devices previously, and I use numbing cream with those 2. But with Ultrasound Q+, I do not use numbing cream unless a patient absolutely requests it. And so far, I think only one, patient requested it, and I couldn't convince not to use it. So only one patient used numbing cream. All the others, no numbing cream. So even without numbing cream, I find that the dot HIFU has pain less than 5. And for linear HIFU, maybe less than 3 or 4 in the majority of patients. Many patients ask, why is this less painful than other HIFU? You might ask the same question. One reason is the increased area energy distributed, as mentioned earlier. Another reason may be related to the speed of the line being produced, which we also referred to. It is known that this machine is faster than other HIFU machines, which can be an advantage for logistical reasons. From our point of view, being able to finish the treatment in a quicker amount of time. But clinically, the fact that the speed can lessen the pain is of greater importance. So here we can see that linear HIFU has a much faster speed per shot for this product U, this product for UF, and then the dot for Ultrasound Q+, and then the linear. So, you might think that being fast is not important for the cartridge speed, but other than being less painful, we cannot ignore the fact that we as physicians, we're human. With limited stamina and concentration, if you're doing 800 to 1,000 shots at 2 to 3 millimeter intervals and it's taking 1 to 2 hours, you'll be more prone to make mistakes and your efficiency will drop. With Ultrasound Q+, I can do 1,000 shots in 30 minutes. This is the graphic user interface. I usually pay more attention to how many shots I've done, the power, and the auto mode. I shorten the length of the line if I'm treating curved areas like the zygoma or the forehead, and I usually leave the spacing at 1.5. So I've never changed this for my patient. I find this is very important for safety issues and for protecting other structures. When I have reduced this previously in other machines, you can get those wheals or the swelling, edema, striations, or maybe even fat loss. But so far, leaving the spacing at 1.5, only adjusting the power or the passes, I've never had fat loss or striations, blisters, those type of side effects. Now onto the literature. Again, I'll try and speed through this a bit faster. You can look them up yourselves, but just to show the diverse range of effects that HIFU can bring more than just skin tightening. So in this 2015 journal done in Korea, they studied the TCPs of 5 different HIFU machines on phantom and cadaveric skin. They analyzed the differences, but there was really not a single device that was dominant in the analysis. There are some companies out there that we know of that say that they're the gold standard. I don't know, where they get that basis from. I think that we need to be a little bit more objective in that aspect. In this white paper done by Dr. Nonak Kyung in Korea, 30 patients were studied using the 2 and 4.5 millimeter linear transducers for the lower face and the double chin areas. An average of about 500 lines were shot, and the sessions were 4 to 6 week intervals. I personally do now in about 2 week intervals, but this was done in 4 to 6 week intervals. Results showed a clear improvement in sagging skin, skin elasticity, fine wrinkles, texture, and tone. It was found that 3 sessions compared to 1 or 2 sessions were favorable, and higher energy with more lines, especially for fat areas, showed better results. This paper, a white paper by Dr. E.J. Hyuk, He performed 2 sessions every 1 or 2 weeks using the 2 and 4.5 millimeter transducers. And the results showed brightening of the skin and increased skin elasticity for all patients in the 2 millimeter group. And all patients showed significant improvement in double chin contour and volume reduction in the 4.5 millimeter group. This paper showed how HIFU can potentially be a modality to treat pigmentations, and it was carried out in guinea pig skin. Group 1 was a control with no ultraviolet radiation and no HIFU. Group 2 was ultraviolet radiation, no HIFU. So group 3 was ultraviolet radiation with low power HIFU. Still, you can see that there was mild improvement in the pigmentations. And group 4 was ultraviolet radiation treated with HIFU at higher power. You can see that the extent of improvement of pigmentations was more significant. Similar results in the dermoscopic pictures. And this is the histology. You can see less melanin in the histology group in group 4 here compared to group 1 or group 2, group 3 or group 2. And the article stated that the mechanism underlying the lightening effects of HIFU is not totally understood. You say, how can HIFU improve pigmentations? No one really knows the answer. It was proposed that the mechanical destructive effects, remember we discussed cavitation induced by vibration and friction, might have eliminated the melanin and pigmented debris similar to fractional lasers. This study from 2017 was done in 20 human subjects of Fitzpatrick skin type 3 and 4, which are the main skin types we deal with here in Asia. The pigmentations were induced on the arm and were randomly assigned to control or HIFU treatment. The Fitz type 3 subjects had less improvement than Fitz type 4 subjects. It was hypothesized that in the type 4 subjects, melanin deposition tended to be more dispersed throughout the skin compared to type 3, and that was the reason for better results after HIFU. All of the type 4 subjects had higher degree of improvement in HIFU treated sites than control sites in objective and subjective assessments. Here you can see the improvement of melanin in the epidermis layer after 4 weeks. We'll skip this. So what about the effects of HIFU on rosacea patients? This paper was published in 2019, and it studied the effect of HIFU on 88 human rosacea patients. The assessment was done long-term, up to 1 year, and the results showed improvement after HIFU in most of the assessments. The mechanism was explained as the TCPs coagulating the blood vessels in the superficial plexus, reducing blood flow, repairing the damaged skin barrier, and changing the Demodex environment. So to dive a bit deeper on how HIFU, especially linear HIFU, can improve on skin erythema, we start with this study which applied HIFU to a rat artery and showed a positive correlation between HIFU energy and blood vessel damage. As the energy increased, there was a reduction in the vessel diameter, then occlusion of the blood flow, and then rupture of the blood vessel. As mentioned earlier, acoustic cavitation occurs leading to oscillating bubbles, which can be stable or inertial, leading to collagen contracture of the outer layers, or direct energy on the vascular wall, leading to constriction or occlusion. Ideally, we want non-occlusive changes, which would require a temperature of more than 43, yet less than 64 degrees Celsius. And this is raw data from the principle on the 2 millimeter linear transducer, showing that the temperature is maintained from the 43 to 58 degrees range, which can lead to contractions of the small vessels in the dermal layers without rupturing them. This is a 34-year-old patient of Dr. Lee with rosacea and telangiectasia. She suffered from frequent hot flushes, dryness, and burning sensations. Total 3 sessions were done. You can see the improvement in her cheek area erythema. A different filter to see the improvement a little bit clearer. Another case of improvement of erythema after 2 millimeter linear HIFU treatment. Improvement of telangiectasia after 2 millimeter linear HIFU. Let's go into a little bit of the clinical considerations. Most of these indications are already well known for traditional HIFU, but with the new linear HIFU, we are able to address additional conditions such as reduction of unwanted fat, asymmetry of the face and neck due to soft tissue, some types of pigmentations, and possibly rosacea or flushing. I think it's very important and essential to assess the areas of concern that the patient has and determine whether it can be addressed by this treatment. If you are not both on the same page, there will be a conflict after the treatment when the patient does not see results on what he or she thought would occur. Always check the medical history, any significant topical products or oral medication, and lastly, if they have any dental conditions, especially implants, which can cause more pain when treating in the perioral areas. I always explain to my patients that there can be lifting, but that the HIFU effects are more to produce firming and tightening of the face and neck layers, which is multi-directional. And there we are trying to prevent sagging as time goes on. If you can prevent sagging and maintain what they have and anchor this for 5 years, 5 years later, they can look 5 years younger than those who just age naturally with sagging. Of course, this is a general statement just to explain to the patient the concept, but some patients expect to have significant lifting, which we all know is very difficult with just HIFU, but is more relevant to surgical facelifting or thread lifts. One of the most important factors to assess is the facial shape and morphology. This will affect which depths and energy you will treat at. You have to check and see the skin hydration and elasticity. If it's too dry, I would hydrate the skin first with other treatments before doing the HIFU. Make sure you know if the skin is sensitive, and if so, take precaution in those areas. Otherwise, you can cause side effects. Combination treatments with HIFU, almost any treatment can be done together with HIFU. Ideally, I would choose to do the HIFU first, lay down the energy, and then after that, maybe do the other treatment. Can be done on the same day, especially for patients who are in a rush. Back when we were traveling and there were medical tourism, patients would do HIFU and then injections on the same day. But if there's no rush like it is now and we have time, then you can do HIFU first and then the other treatments subsequently. I don't think there's any absolute contraindication for HIFU, but I would be careful in doing it for patients who are too elderly with severe skin laxity, active acne, severe rosacea, maybe recent unknown filler injections, and especially those who have unrealistic expectations. Side effects and complications are very rare. Pain, some redness, some swelling, maybe loss of fat. But I think if you adhere to some of the principles that we discussed today, that will not be too much of a concern. Striations, blisters, burns, neuropraxia, bruising. I think miscommunication is a major cause of these types of side effects. So this is an example of striations, courtesy of Dr. Icharu in Seoul, using a 2mm transducer at 3 joules, 1.5mm interval. If you see these, don't be too alarmed. Most will subside. I think it's a bit more riskier on the neck. You can prescribe a mild topical steroid to apply a few days and it should improve. To prevent this, we should lose lower energy in thinner skin patients and keep the cartridge perpendicular with complete contact on the skin. And there's another example of striation, another example of striation on the forehead with erythema. If you can see here, the blister here on the neck. I always explain to the patients that this is a possibility, but that it is treatable. However, after the blister subsides, there can always be PIH. So this could be more of an Asian concern, as some Asian patients don't like the hollowed look on the cheeks or the supermodel look, whereas in other cultures, this might be more desirable. So in patients who have less subzygoma fat, I think you have to be careful when using the 4.5 and the 3mm cartridges in this area. This is a very good paper of 5 patients using the U device. Review of literature of the side effects. These are very unique and rare cases of severe complications, which most have never seen and hopefully will never see. But it's important and I think necessary to inform the patients of the worst case scenarios before the treatment. And also, this is related to the need for sufficient understanding, selection, parameters of the different transducers, having enough patience and proper technique to reduce these risks. When you know you have a long procedure ahead of you and you start to rush, that is when complications can arise. So the fact that this HIFU Ultracell Q Plus has a faster shooting time and shortens your treatment time can actually help to reduce your risk of side effects indirectly. The main side effects in the review portion of the journal were wheals and welts, but please check this paper out if you have time. Some common causes of side effects are inadequate contact with the skin. This can be caused by having too many air pockets in the gel, from having too much gel, or due to the gel type. Some say Parker gel is better. I personally just use Parker gel. Inverting the transducer, especially in the submandibular area, when you're going like this and you can't really see under the mandible area and there's poor visualization, you don't know the angle, is there good contact, you're at risk. When you're treating the side of the face, which is your non-dominant side, it can be more difficult also because you're not as familiar using your non-dominant hand, especially under the mandible. When you're treating curved or bony areas like the forehead and the zygoma, it's common to have poor contact, making sure to shorten the line length accordingly. Then there's stacking, which can happen when you're rushing. It's not like you intentionally stack and do, the shot on the same place on purpose. But when you're rushing and you're going, and sometimes the transducer doesn't move as you want to, and you're using the auto mode with the trigger held down, boom, boom, you already stacked, and it's already too late. So you have to be careful about that. And you have to be careful when you're using higher energy and the narrow space interval. Again, I said I do not reduce the 1.5 millimeter interval. I keep it at 1.5. I've never touched that button. And improper cartridge selection. So when we talk about cartridge selection, this is a picture we all know about, we're familiar with, but actually you can treat some of these areas like on the forehead and the chin. These are areas we can't treat and we need to treat. I mean, there's wrinkles in these areas, right? I mean, if we avoid these areas, what are you going to use to treat these areas with? Are you just going to let them sag and age? There's the corner of the mouth, the marionette lines. There's forehead wrinkles here. So you can still treat these areas as long as you regulate the energy and use a shallower depth transducer like a 1.5 or 2 millimeter. So if you use a 1.5 and 2 millimeter cartridges, it's very unlikely to cause nerve damage to the marginal mandibular branch, which runs across this length. And I also treat these areas, with the 1.5 and 2 millimeter. For the forehead, I also use only 1.5 and or 2 millimeters. So far, no problems at all. When you start to use 3 millimeter, you increase the likelihood of encountering neuralgia, especially on the lateral forehead areas. And 4.5 millimeters, I really don't understand why anyone would use a 4.5 mm on the forehead. Practical applications, first to look at the dot transducers or the Q cartridges. For the Q 4.5 millimeter, I only use it sparingly on the lateral neck, for the platysma and the lateral face. Q3mm is a workhorse for me. It's very safe and versatile. If a patient has very little fat, hollow cheeks, and concerned about fat loss, maybe sometimes I will skip the 4.5 and just start with the 3mm. On the cheeks again, I use the 4mm for the lateral aspects only, or for the lower cheeks where there's a lot of fat. 3mm can be done on most of the neck and cheek area, but I usually avoid the perioral areas unless they have thicker skin and more fat in these areas here. For the nasolabial fold, I use the 3mm for deeper treatments with more lines. But in the majority of cases, I use the 2mm. Since the 2mm cartridge has a smaller head, which allows more accurate placement in the nasolabial fold area, I place the lines parallel and then perpendicular to the nasolabial fold. But you need to be careful about the pain in the maxilla areas if the patient has tooth implants or sensitive teeth. For the periorbital area, similar to the nasolabial fold, I use the Q3mm for deeper treatments on the temples and more lines using the 2mm in a radial pattern around the eyes. Again, the smaller head of the 2mm allows for more accurate and safer treatment. You can see that the skin is roughly around 2mm thick, which is ideal for the 2mm transducer. And of course, you can use the 1.5mm, but due to the size of the cartridge, detailed placement of lines is not practical using the 1.5 mm. This is the 2mm dot cartridge. You can see that the size and the shape is more suitable for treating tighter areas like the perioral and the periorbital areas. So when using the 2mm dot cartridge, the most important thing is to, of course, protect the eye. So have a habit of palpating the orbital rim, knowing where it is, and if you need to, mark that area out. Pulling down the skin with the finger, or you can even use the transducer to use this as leverage and to pull down and then fire the line on the area. Making sure that you angle downwards, okay, don't angle upwards. And to have perpendicular contact, actually, this is really not the direction you need to be. You need to be actually slightly at a downward angle when you're treating this area. For the forehead, I personally use the 2mm due to the curvature and higher probability of striations or wheals. I think it's important to lower the energy 0.1 or 0.2 joules more than what you're using on the other parts of the face. If the patient has more severe wrinkles on the forehead, you can add on the 1.5 millimeters. Now on to the linear cartridges, which are the 4.5, 3, and 2 mainly for the face, sometimes the 6mm. Double chin treatment is really where the linear HIFU has an important niche. In a context like Singapore, here where injectable lipolysis treatments are not permitted or patients are not keen for invasive methods, this non-invasive method for reducing fat in the submandibular, submental, and lower cheek area is really game-changing. I usually use the 4.5 mm the most, but in cases where the fat is thicker, you can use a caliper to check. You can use the 6 mm also. I usually keep the lines very close, about 2 to 3 millimeters apart, and treat with a total of about 400 lines. The 3 mm linear is also very versatile. It can be used on the neck, cheeks, and especially on the nasolabial fold areas. For the 2 mm linear, I use it for areas usually treated with HIFU, anywhere like the neck, cheeks, temples, but I do not use it on the forehead because again, for the linear 2.0, you cannot adjust the length of the line like you can on the dot on the forehead contour. So this can cause a side effect. So I don't use the linear 2 mm. Hopefully they'll come out maybe with a smaller head one, and then we'll be able to use it around more tighter areas. So for fat reduction in the submandibular or cheek areas, depending on the thickness of the fat layer, use 6.6 millimeter linear, 4.5 millimeter linear, and or 3 millimeter linear in combination during the same session. Start deep. And then move your way up superficially. If the patient also has skin laxity, I add on, I add on the Q2 mm and or the Q3 mm and do the treatment every 2 weeks for 3 to 4 sessions. So you really have to assess, the fat content and also the skin laxity. And depending on that, choose between the linear. If there's more fat, more of the linear. If there's more skin laxity, then more of the Q dot cartridges. As a general rule for utilizing dot and linear cartridges for better clinical results, I think the important point is to layer the energy on top of each other. Again, even though we cannot visualize the SMAS, like mentioned before, the SMAS might not be as an effective target as we assume anyways. However, as we saw earlier, there's a fibrous connective tissue network from the periosteum all the way to the epidermis. So just start laying down your energy from deep to superficial. With the Ultracell Q+, you have the additional advantage of being able to insert additional energy in linear form with larger volume. Imagine trying to hit a volleyball net with a golf ball. You're throwing a golf ball at a volleyball net, it's just going to pass through. You can't hit the net. The net is a fibrous connective tissue. It's not easy. But if you throw a golf club at the net, you're definitely going to hit it, and that's the linear. So for example, say you're in the lower cheek where there's a lot of fat content, you can start with the 6 millimeter linear, then the 4.5 millimeter dot, the 4.5 linear, then the 3 millimeter dot, 3 linear, and then the 2 millimeter dot, the 2 millimeter linear, and then finally the 1.5 millimeter dot. I guess, I don't know, I just call this a pancake technique, layering as many levels of energy as possible to tighten the fibroseptal network in the whole thickness of the face and neck. So we're not just talking about skin rejuvenation. This is really more holistic, full thickness tissue rejuvenation, not just skin. We're not just dealing with the skin here. And always finishing with the 1.5 millimeter. Of course, you need to know the average depths in different parts of the face and neck to know which cartridges to start with and customize for each patient accordingly. And we often think of the TCPs forming from HIFU like this, right? We've seen this picture millions of times, and we say, oh yeah, the HIFU comes out in these dots like this. And we see this in tissue studies, in actual histology and in phantom. We can see that this actually does happen in sequential circular small areas. But in this paper from Korea in 2015, you can see the tissue coagulation from a 3 millimeter transducer is not very focal, like it's commonly portrayed as, like in the previous slide. On the contrary, there is a column of coagulation. For the 4.5 millimeter, there are prefocal coagulation areas. So this is the focus point here. So they're prefocal, and there are postfocal coagulation areas that are deeper than the focal point. So we have to remember that there is still heat around the focal point, which can cause thermal effects. And remember, there are also the acoustic cavitation effects we mentioned earlier in this whole column of ultrasound, in this whole area, which we can see here. These are the acoustic effects. So even though the focal point might be here, through this fluid jet, that can cause different changes in the tissue above or below the focal point. This article from Korea in 2016 also showed that HIFU TCPs have a column of coagulation about 2.5 millimeter on average in length for the 4.5 millimeter transducer. So firstly, I see this as an advantage in that we are covering more area than we think. And so maybe it's not really just a golf ball that we're throwing at the volleyball net. Maybe it is really, more, it's longer, like a football or a rugby ball, depending where you live, at the volleyball, at the net. Secondly, the significance of seeing or visualizing and accurately placing the TCPs at the SMAS or a certain layer is probably less than what that company states. These are the cartridges for the body, which have deeper target depths, can be used for the arms, for the flanks, for the abdomen, medial thighs, even the lax skin above the knees. And we got to the video demonstration. Okay, let's go. Sorry. Can you not hear? 1 second, sorry. So sorry, I think there's no sound. Okay, I think I need to stop share for a moment. Apologize for that. One of the first things that we want to do before we start the treatment is mark out the areas that are of concern. It's important to do this step before the patient lies down because we want to see how gravity is pulling on her face. And this is what the patient sees when they are looking in the mirror. They're not looking in the mirror while they're lying down, but while they're upright. This is how you will meet people. So we need to see how the face looks, where are the sagging areas, where are the concern areas when the patient is upright. Of course, when we lie down, that's going to change a little bit. I'll discuss that. But we do this first just to give us an idea of where we need to treat first. So this is giving sort of a roadmap of what we need to go and where we need to go. So we will start with the tear trough. This patient is actually quite young, so she doesn't have much volume loss or sagging skin, but usually there will be a tear trough that we will draw here. Also, the nasolabial fold is also an area of concern most of the time. And then there's also the jowls, which will form a little fold here to the corner of the mouth. And then we'll turn to the side a little bit, and usually there'll be a little bit of a subzygoma depression. We don't want to aggravate that. So if it's hard to see first, you can also use some tangent light and see where the shadow is. So there's a little bit of subzygoma depression there. So we don't want to focus too much treatment in this area. And then also in the preauricular area, draw a line down just to mark out the borders. And then also the border of the mandible. And so patients who have some sagging or prominent jowls or nasolabial fold, usually I'll also draw out that area. And also the nasolabial fold will usually be in this type of formation here. And then also sometimes I'll also draw out the zygoma, this area here. Okay, because on the zygoma also the pain will be a little bit more prominent compared to the rest of the fleshy skin. So now we will lay the patient down. So we also need to mark out the areas of the neck, and I'm going to do that while the patient is lying down so we can have some retraction here. The submental area is usually an area of concern with the fat, and with the linear cartridges we are able to reduce some of the fat in this area. So we will mark out the area. There's usually a little bit of a margin between the submental area and the thyroid cartilage here. So we'll draw a line there. And then we'll feel the thyroid cartilage to the side because we also want to avoid the thyroid gland. Okay, and we'll do that on both sides. Okay, and we also want to mark out the areas of the mandible because this is an area that will be painful if we treat with deeper cartridges. So you want to palpate and feel the bony areas and mark out the margins. Because we can treat with shallower cartridges like 2 millimeter or 1.5 millimeter, but with the deeper cartridges like 4.5 or 3, there can be some significant pain along the bony mandibular area. So feel along for the margin so you know where you are later on. When there's a lot of gel, sometimes it's hard to trace where you're going. And then the preauricular line will be our lateral border here. So this will be the area that we'll treat on the lateral neck to treat the platysma and also the submandibular fat area here, or for tightening we'll just use the duct cartridge. Another area, and the last area I'll mark out, is the crow's feet area. It's an area that we definitely want to treat. So from the lateral canthus, I'll draw a line here so I know that this is an area we want to treat. This will be the midline. Also, I'll draw a diagonal line from the lateral margin of the eyebrow to the hairline. So this will be the margin of where we'll be treating for the crow's feet, and then this will be treating for the forehead. Treat with a 2 millimeter cartridge around the eye area. I will usually just palpate and not mark out earlier, but if you want to, you can palpate earlier, especially in older patients where there's a lot more volume loss. You want to feel and palpate where is the edge of the orbital rim, and then you can mark that area out just for safety reasons so that you want to make sure that you're not going inside that area to protect the eye itself. So we can treat also this upper eyelid area where it's on top of the orbital rim, but there is a little border here, so if you want to, you can mark out that area as you feel. And then this is the area you can treat. When it comes to fat reduction using the linear cartridges, it might be helpful to use a caliper to check the thickness of the fat in the skin. So to check the fat thickness using the caliper, we'll pinch the skin and the fat here, and then gently use this, and then we'll be able to see the thickness. Remember that this is the tissue folded over, so we need to divide this number by 2. So right now it's about 10 millimeters. If we divide that by 2, that's 5 millimeters, so we can use the 4.5 millimeter, but not the 6 millimeter in this area. Before starting the treatment, I think it's important to have the patient lift their chin. Otherwise, you're going to have a very small window of treatment in a small area. So we want to treat this area as efficiently as possible. So I ask the patient to lift their chin. Can you lift your chin, please? As much as possible. Thank you. So having a neck pillow underneath can help to assist that. So if the patient wants to reduce fat, it's usually in this area, in the submandibular area, not in the lateral neck. So for the lateral neck, you can consider using the 4.5 millimeter dot, but for fat reduction and tightening in this area, if the patient needs it, then we'll use the 4.5 linear. With the linear cartridge, there's no option to change the interval, obviously, because it will come out in a line. For the length, I do not usually change that. For the power, depending on the area and the pain tolerance of the patient, you can adjust this. However, when it comes to fat reduction, I do find that using multiple passes with lower power or one pass with higher power can be similar in effect, but it also depends on the time that you have and the patient's pain tolerance. Another important function is the auto. So this will mean that if you turn this on, it will continue to fire. 0.5 is the interval between each shot. So usually I'll keep it, when you're a bit more experienced, you can go to the fastest 0.1.
But sometimes it takes a little bit of training and getting used to it, and you might not be able to move accordingly. So then if that's the case, you can always make it a little bit slower and then take your time between the shots.
Sorry for being out of focus.
This is the 4.5 linear. We're at 0.6 joules with an interval of 0.2. So we'll start 3, 2, 1.
Usually I'll go up to 0.8, 0.9,
So when treating the
1.0,
submental area, make sure you're
1.1
not on the thyroid
4.5
cartilage.
linear for fat
Palpate and feel
lipolysis.
that you're on the fatty area. And remember that when you're firing, that the firing position is in the middle of the cartridge, not at the edge. So you have to calculate and compensate for that. So I'll push in a little bit and then up.
But I think it's also very important about the number of passes that you do
Up to the border here. If you fire onto the bony area here with a 4.5 or 3, usually they'll have some severe pain. So some doctors will prefer to draw lines on where they're going to treat. But if you have a good knowledge of how wide the treatment area is, you'll go adjacently. When the patient has complaints of sagging jowls or lower cheek area and prominent fat protrusion, we can use the 4.5 linear, but again, avoid the bony mandibular area and focus on the fleshy areas. Since the patient is lying down, what was seen when she was sitting down here might have already displaced posteriorly to this area. So even though you drew this area up here anteriorly while she was sitting down, when the patient lies down is back here, this is the area you need to treat, and you need to keep that in mind. So we will use the 4.5 linear on the fatty areas, but the patient can feel some discomfort in their teeth, especially if they have crowns or implants or sensitive teeth. So you have to be careful and make sure that if they feel some discomfort, you can put some gauze in there, or you can ask them to blow a little bit of air in their cheek. Blow some air in your cheek right now, and from that state you can treat, and it can help to reduce the pain that they have if you really need to treat that area. We'll put the cartridge down onto the bony mandibular area and then move slightly upwards from that area and then start treating from there. And then you don't want to have too large of a space between each shot. Make sure you just move very minimally to the next column. So this area here, you have to be more careful because of the neurovascular complications that can occur here. So usually in this area here, I do not treat with the 4.5. With the 2 or the 1.5, there's no problem at all. With the 3, depending on the patient's condition, you can consider treating here. But with the 4.5, this area I do not treat. So avoiding this area here, starting from here, if you want to do a second pass, you can do one crisscross. Make sure you're perpendicular to the skin. Forewarn the patient we're going to start. Okay, we're going to start right now. 3, 2, 1.
Sometimes they get shocked because of the pain in the nasolabial fold area here.
As you move along the contour of the cheeks, make sure you follow and adjust your handpiece so that you are perpendicular. Comes to choosing the 3.0 millimeter cartridge, you have to choose whether you're going to use the dot or the linear. You can also use them in combination. If the patient has more flesh, more fat, and needs more fat reduction, definitely you can consider using the linear 3.0. If the patient does not have much fat, they have a skinnier face, or they're concerned about fat loss, then you can try the 3 millimeter dot cartridge. And if the patient might have some concerns about the fat underneath the submandibular area, then you can use a 3 millimeter linear in this area. For the cheek, they might not have that concern, and they might have volume loss, and you can use the 3 millimeter dot for the cheek area. So same as with the 4.5 linear. We're going to
Or you
start
can use
just
both.
above the thyroid cartilage where you can feel the fat in the flesh. Slowly move up. And as you're moving up, make sure you have adequate pressure to keep good contact, but not too much to cause discomfort to the patient. And as you approach the bony area for the 3 millimeters, not too bad. Some patients can endure, some patients can't, but you have to be a bit more cautious when you're treating on the bony area here. So I'm about to start using the 3 millimeter dot cartridge, and for the dot cartridge I usually do not change the spacing. Now previously in other machines I did adjust the spacing, but I feel that using 1.5 millimeter is the safest and most effective spacing distance. If some people think that if you decrease this, then it will increase the effect, give you better results. But I also feel that the pain exponentially increases and also can cause some side effects like wheals or little striations. So in my experience, I always leave it at 1.5. The length, of course, you can change a little bit if you're on contouring curved areas like the forehead or the zygoma. So that's how I usually approach the settings for the dot. So we're going to use the 3 millimeter dot, and then we'll start at the lower mandibular margin. And then just make sure that you slowly move upwards in very small increments. As you approach the zygoma, pain can increase a little bit. Make sure you adjust your handpiece that you're always perpendicular with good contact to the skin. Doing the second pass, I'll usually do it at a right angle to the first pass that I did. Patients will also want to treat and prevent the jowl from sagging more, so we can treat this area again because of the marginal mandibular branch nerve here. You want to be a little bit cautious with the 3 millimeter. You still can treat, but just not with too high of a power. So you can start here and then slowly move your way posteriorly. Until you reach the preauricular area. And then also patients who have nasolabial fold. This patient does not have a very significant nasolabial fold, so that's why I'm going to be using the 3 millimeter dot, but you can use the 3 millimeter linear for this area. And when you do, I just go parallel to the nasolabial fold. This first shock can be a little bit painful to the patient, so caution is required.
Actually, it should be a little bit more closer together.
In my opinion, the 2 millimeter dot is a very, very excellent cartridge, and it's very versatile. So I'll show you the areas that we can treat, especially around the perioral areas, on the lateral chin, marionette lines, and then also the nasolabial fold. We can also move upwards, the paranasal area up to the infraorbital area.
So using the QS
move laterally across to the crow's feet,
2.0
up
millimeter
to
requires the
the
most
margin
precision.
with the forehead, and then also the forehead and upper eyelid. So this is a no treatment zone for the 4.5 and deeper cartridges, but for especially for the 2 millimeter and the 1.5 millimeter, there is very little risk of neurovascular complications arising here. So I'll move upwards.
Thanks everyone for
And then when
staying.
you're close to the infrared area, make sure just palpate
We're approaching the
where
end.
the
After
edge
this,
of
there are
the
a few more
orbital rim
slides,
is.
and then
Make sure
we'll
that
be
you're
onto the
on
Q&A.
bone. And to be perpendicular, you have to be actually facing this way, distally. If you're facing proximally, you're not only not perpendicular and having poor contact with the skin, but you have risk of injuring the eye. So always make sure that you're perpendicular, adequate contact, facing distally. And then if you want, you can also pull down with your hand or with gauze on this area. But I find it's a little bit slippery, so you can just use the cartridge itself and then put and then retract. And also as you push down, you can sort of feel that you're on bone. If you're not on bone, it's going to be very soft. But when you're on bone, you can feel that resistance. You can feel that you're on the bone, so you know you're safe. So make sure that you're safe and then you can fire, and then maybe just a few additional ones going down. Okay, and then you can make your way around also.
See, I use the transducer to sort of push the skin.
And then don't forget the crow's feet. So I'm gonna go here, make sure you palpate the lateral orbital rim, which is very close to the eye there. Some doctors don't recommend treating near the supraorbital nerve or even to the lateral forehead, but I think this only is relevant to the deeper cartridges like the 4.5 millimeter, especially I never use on the forehead. Even the 3 millimeter I don't use on the forehead. However, using the 2 millimeter or 1.5 on the forehead, there's no issue. You can treat the whole forehead and even the upper eyelid, and we should be treating the upper eyelid as much as we can. So this is the 2 millimeter, and if there's a contour, remember this is 25 millimeter, maybe you want to change it to 20 millimeter. I use either 15 or 20 millimeters on the forehead or upper eyelid. So when you're treating the upper eyelid, again, palpate, make sure that you know where the bony margin is of the orbital rim. If you need, you can retract using some gauze. This patient doesn't have much sagging, so it's not really necessary. Remember, you're not treating here or here, it's the middle where the energy is coming out. So it can retract. I've shortened the length to 15 millimeters. Okay, again, try not to direct your transducer downwards, but perpendicular to the skin and upwards so that you're on the bone, opposite from when you're in the infraorbital area. So you'll be facing more cranially. The forehead is it's not that stressful, but it's a little bit challenging because everyone's forehead is a little bit different. There's also different contours that you have to deal with. I haven't had any striations yet using the Ultrasound Q+, but you have to make sure you have good proper contact with the skin and make sure that you're perpendicular. You can go horizontally like I am now, or you can also go vertically. The 2 millimeter linear is also very versatile. This is not for fat reduction, but actually more for skin tightening, skin rejuvenation. So it can be used in areas of the neck or the face. It's just that it doesn't have that tapered edge like the 2 millimeter dot. So it's smaller, it's wider, so it's harder to go into smaller areas. But using this for the neck, for the cheeks, to create bulk heating for more skin tightening is something I do next, depending on the skin laxity of the patient. The 1.5 dot is the last cartridge I'll always use with the patient. This is the most superficial. This can help with skin tightening to also improve on the pores. So areas along the cheeks or the neck, crow's feet, upper eyelid, forehead that need extra tightening, I will finish by using the 1.5 millimeter dot. Because it's superficial, you want to be careful that you're not at too high of energy and not too small of a space. Again, I leave mine at 1.5 millimeter. Otherwise, you might get some striations or edema. Because 1.5 is so superficial, this is one cartridge that you can confidently go on the mandibular area without causing pain.
Okay, I think that's good. So thanks for almost everyone staying through the video, and just a few slides about practical tips, and then we'll go on to the Q&A. So during the consultations, have visual aids and slides to explain and manage expectations before the patient decides to do the HIFU. Have a detailed informed consent prepared to be signed before the treatment. And I like to plan the parameters before I go in. because sometimes when you're on the fly, it takes time to process. So, looking at the patient's pictures, their skin analysis, and saying, okay, where do we have to contour? Where's the skin lax? Sort of have that plan before you go in. Make sure the cartridges are full of water. There's actually a little plug here. And when you buy the cartridge, it comes with 3 bottles of water, so you can use a small syringe. Just make sure you can shake it. So this is a little bit empty. You can hear the water rattling around, so there's air inside. So try and always make sure that this is full. And make sure you have adequate time and patience for the procedure. You don't want to be rushing through the procedure. Okay. Immediately before starting in the erect position, like I said, discuss and ask with the patient again, where do you feel are your concern areas? Where are your sagging areas? Mark out the areas. I don't use a pillow, because if you use a pillow beneath the head, it will be like this. And if you're behind, it's not going to be a good vantage point. You won't have good visualization. So I only use a pillow just for the neck. Your assistant has to be trained well. Record the settings and the lines as much as possible, because hopefully these patients will be coming back to do the treatment again. So you have a good reference. Okay, in what area, how strong did we do it? How many lines did we do it? I think documentation is very important. Start with lower setting and then increase, of course, as the pain or skin permits. For the dot, I explained before, keep the length of the line default at 25 millimeter unless you're on curved surfaces and you reduce it. Keep the interval or pitch at 1.5 millimeters and 4.5 mm only for patients with more fat in the lower facial areas. Always do a test shot first. Some patients have surprisingly low tolerance of pain, so you want to do a test shot first. And always tell the patient, when you do the test shot, they might say, I feel nothing. But after you do about 10 shots, they're like, ow. So, you have to tell them, okay, it's going to get a little bit more intense. Let me know how it feels as we go along. And this is just my personal take. I don't talk excessively during the procedure, not only because of the COVID situation, but when you're talking, you can be distracted, and you really need a lot of concentration doing so many lines and so many shots. The patient is talking, moving the mandible, and that's going to cause improper contact. So I tell the patients, it's not that I don't want to talk with you, but during the procedure, it's going to be a silent procedure, except for when I'm asking you, how is the pain? So please understand that. Start with the slower auto mode. The auto mode is when you pull down the trigger and it's going to keep firing. If you do it at the fastest, there's going to be some problems. Stacking is one of them. And I'm going to show you later another problem. And just like, when you're driving, when you're going on the curves, don't be, we don't want to be too, fast on the curves, and take our time for good contact. Yeah, don't stack. Don't stack is very important. And when you're going near bony areas, especially with the 4.5, warn the patient, it can be a little bit more painful. Start with the deepest cartridge and then move your way up, like I explained with the pancake principle. Don't be afraid to move the patient's head and the neck. You need to have proper positioning. That's better than getting a complication. After you do one side and then you turn the face, go to the other side, take a look on the other side and see what it looks like. Sometimes the face turns really red. There's a lot of erythema, so it's a little bit delayed. So always, take a look and see how the skin is reacting. If you're doing a second pass, usually I let it rest a little before I come back to it. I talked about the gauze in the cheek or blowing a bubble of air in case the patient has sensitivity around the mouth. And be careful of your slippery hands with touching the gel and touching the handpiece. Things get slippery, and that's where mistakes happen. When it comes to the linear, determine the areas to treat with the linear before you go in. There's so many cartridges. I have all the cartridges out. You have to have a plan before you go in. Okay, what cartridge am I going to use for this patient? And each patient is different, so you need to decide that before you go in as much as possible. So the 4.5 linear, the areas needing fat reduction, the 3 millimeter for lower energy for tightening, the higher energy for lipolysis. The 2 millimeter linear is areas needing more bulk heating. Always start at a lower power and increase later. Be careful when you're using the auto mode, because it's very fast coming out compared to the dark cartridge. And in certain areas, warn the patient that there can be that sudden shock or sudden pain, especially like around the nasolabial fold or around the mouth or around the mandible area. Last point. Okay, are you having less results despite maybe using a high number of lines? Maybe you're using 1,000 lines or 1,200 lines or 800 lines, but you're not getting the results that you expect. one thing we may have to think about maybe is shot accuracy and efficiency. How many effective lines are we firing? Not total lines, but effective lines. What is our success rate? This is how the TCP should be placed if proper technique is used. However, if you're moving the handpiece too quickly before a line is completed, or if you use the motion technique, like some people I see on social media do, then before the energy is delivered, it's moved and you drag and you go to the next line. And the more you do that, the more accurate TCPs you lose. And this can lead to maybe 20% or more loss of effective TCP placement, which can affect the clinical results. So make sure you don't move too fast between lines. Again, be patient, plan out the time. You have to have the time, you have to have the patience. The machine is fast, but don't go too fast, and then you're gonna lose some effective TCPs, which can reduce your clinical efficacy, and you're putting in the time anyways. One of my body contouring machines, it tracks movement during the energy emission, and it calculates these as misfired shots. It will then tell you in the summary at the end of the treatment, your shot accuracy. And the lower your accuracy, the higher the chance the treatment will be less effective. Of course, we don't have that function here, but it's something I think that we should be keeping in mind. So the take-home message, SMAS visualization, I think is overrated. The fibroseptal network, underrated. Ultrasound is more than just heat. Remember the bubbles and the cavitation. Linear is the new HIFU. Remember we talked about the cold rejuvenation. The pancake principle, using multiple layers with multiple cartridges. Make every shot count. We talked about the accuracy and the efficiency. So last slide, let me just say, this little machine looks very humble. It doesn't look very sophisticated like other HIFU machines might. But used properly, it can provide wonderful clinical results. I can honestly say this little machine has kept me afloat during the pandemic. It is small, but so very versatile and powerful. Sort of like R2-D2 in the Star Wars movies. I'm a big Star Wars fan since I was a kid. R2-D2 is small. He's considered the sidekick. But if you really think about it, he was instrumental in all the major victories. So you have R2-D2 by your side. You just need to train a little, and you can soon be a HIFU Jedi Master. Okay, thank you for your attention. Thank you for all of you who have stayed to the end, 175 of you. And I think I'll hand it over back to Jesus. If you have any questions, comments, you want to DM me, I'm on Instagram. You can also email me. Yeah, appreciate it. Yeah, look forward to keeping in contact with you guys.
All right, thank you so much for your detailed explanation, Dr. Kim.
Thank you.
And we will be starting, we have some of the Q&A session, Q&A questions for your Q&A session.
Yeah,
so
sure.
Yeah, we'll be starting right now. I'll be reading out some of the questions and you can answer my question. First one is, what is your parameter for double chin reduction?
So this is really different for each patient. A lot of it depends on, again, how much is it fat accumulation? How much is it skin laxity? What is the pain tolerance of the patient? How sensitive does the skin get? How much erythema do we experience? But in general, doing double chin reduction, the most common cartridge I use is a 4.5 millimeter linear and the 3.0 millimeter linear. If there's more thicker fat, then I even go to the 6 millimeter. When we talk about energy, start low, I go high. So maybe I'll start around 0.7 joules, do a few shots, see how the patient responds. If the patient has good tolerance, then I'll increase it, maybe to 0.8, 0.9. But again, this is not going to be a one-off session. This is meant to be done 3 to maybe 6 sessions, 2 weeks apart. So it's not going to be the last time we're doing it. So they might respond to this lower fluence at 0.7 or 0.8. So do that session first. And then also see, of course, the skin reaction. Is there mild erythema? We should see a little bit of mild erythema. And then at the next session, you have to assess. You have to ask the patient, also look at the patient, see was there improvement or was there no improvement, or so if there's a need, we can increase even to 0.9, 1.0, 1.1 even. I think maybe occasionally I increase to 1.2, but above that, usually I don't go. There are some papers talking about it's more important to do multiple passes with low fluence compared to high fluence with a single pass. So I see there's credit to that, even in my experience. Of course, you can't do too low of a fluence, and you have limited time, so you can't be doing limitless passes. So you sort of have to find that balance, I think, there.
All right, thank you. For the second question, if the patient has already received other treatments such as filler, Botox, or thread lifting, what is the interval for HIFU treatment? Also, what's the interval for PRP and invasive treatments?
What do you mean by invasive treatments? Like, what do you mean by invasive treatments? I'm not sure what the question, the one who asked the question is implying. Well, first of all, PRP is not approved in Singapore, so we cannot do PRP. We do polynucleotide or Redron injections, skin boosters. Maybe that's what you're implying. So first of all, I'm not aware of any official published studies that show there are complications of doing HIFU after these type of procedures. There's a lot of rumors, I guess, or talk or recommendations, but I don't think there's any official studies on how HIFU could affect the duration efficacy of Botox, toxin, fillers, or threads. There might be. If there is, let me know. So for me, if it's my patient, I always try and recommend we do HIFU first. HIFU for me is really the starting point. What I explained in my presentation in the beginning is what I explained to my patients also. And HIFU is really the basis and foundation that we start from, and we build on that. It's like building the foundation of a building. That's what HIFU is for the tissue in the face and the neck. And then, we'll go on to different injection treatments if needed. But sometimes, yeah, patients do come from another clinic. They've done filler, toxin, or threads at another place, and they come to you for HIFU. That's always a possibility. For toxin, I'll wait maybe at least 2 weeks. We know that the effect usually will increase up to about 2 weeks, and that's where we see the maximal effect. So say you do it after a few days and the patient has some complaints about the toxin, but blames you for doing the HIFU. What are you going to say? You're really stuck there. So, let the toxin take its place, let it take its effect. After 2-3 weeks, or maybe even a month, you can do let the toxin takes its effect, and it's there, it's set, so the patient knows what the toxin does, and then you can do your HIFU treatment, without being blamed for any subsequent toxin complaints. When it comes to fillers and threads, the concern is that the HIFU energy will somehow degrade the filler, thus lessening or shortening the duration. There's no studies that I know that officially prove that. Also, when it comes to threads, the same applies. I've talked with many doctors, and I've asked the question many times also myself. So I think there is no set rule for this. But I would wait, at least maybe 1 or 2 months to allow the filler product or the thread to stabilize. You never know, there might be some side effects or some problems with the injection or with the thread, and we don't want to be blamed for that. So, let it take its course, let it be stabilized a little bit. Let the patient also see the effect that they need. Who knows, they might need some treatment to dissolve, to hyalase some of the fillers because they're not satisfied. But let that be decided without you doing the HIFU first. So in my opinion, I'd let it stabilize at least a month, maybe even 2-3 months if needed. For maybe invasive, I don't know, invasive treatments, I don't know. I don't think surgical treatments. I don't do surgery, so I'm not sure about that. When it comes to maybe skin boosters or polynucleotide type injections, again, if they come somewhere else, because I would do that after HIFU in my clinic. If they come from somewhere else, I let them, heal maybe about 1 month at least before I consider doing the HIFU for them.
Okay, thank you. For the third question, can jowls be treated with linear cartridge, and especially when the patient's skin is thin?
Right, so I guess you mean like the sagging jowls. And again, we have to assess, what is the cause of the sagging jowls? How much of it is due to excess fat and the sagging of that fat layer or the subcutaneous layer, which we discussed earlier? Is it really empty and just a lot of lax skin that is on the top? If there is a lot of lax skin and not a lot of tissue that is sagging, but just the skin is very loose, definitely there's going to be a limitation to what HIFU can help with that patient. However, if there is general sagging of all the tissue in the area here downwards, and the skin laxity is still mild to moderate, I still think there is possibility to improve on that. But you can't give the patient unrealistic expectations. You can't tell them that the jowl will be gone or that it's going to be lifted. I always manage the expectations. I tell them, first of all, it's to prevent it from getting worse. Preventing getting worse is our main goal. You cannot see prevention. It's something that you will see. If you don't get it, that's a success, but it's not something that you can see. Of course, if there's reduction and improvement of the skin tightening, to me, that's an extra added benefit. It usually does come in. We usually do see the results, but you cannot expect the patients and tell all the patients that they're going to get that. So it's really different for each patient, and you have to be careful around this area because it's a sensitive area. There's also the marginal mandibular branch. So, you can't, I wouldn't use too deep a cartridge. The deepest I would use would be the 3 millimeter, and then layer 3 millimeter dot, 3 millimeter linear, 2 millimeter dot, 2 millimeter linear, 1.5 dot, and just pancake it, layer it, all this, and not just in this vector going up, but also into the superlateral vector going up this way. I think is important to treat also.
Right. For the fourth question, is 2 millimeter linear cartridge effective for melasma?
Well, first of all, I've never seen a case where it's aggravated melasma, and that's always been a concern in my earlier years of practice. This patient has really severe sensitive melasma. Can we do HIFU? There's heat. Is it safe for this patient? And the patient will ask this question too. And when we're doing HIFU for melasma, severe melasma patients, you can see it darkening sometimes, right? Because there is heat that goes into the tissue, and that can cause the pigmentations to not only look darker, but maybe be darker temporarily. With Ultracell Q+, I've never encountered a case where the melasma aggravated. If a melasma patient comes to me and we consider doing HIFU, of course, I will warn that the worst case scenario is that the melasma can aggravate. There's always a possibility of PIH, but from experience, empirically, I've not experienced that happening. Is it effective to treat for melasma? I wouldn't consider it a first-line treatment. We did see some papers, some articles on how HIFU can improve on pigmentation, but those were animal studies. And of course, one was on the forearm, but it's not melasma patients. So it's hard to really say, can it improve on melasma? I would not, we use different modalities for melasma treatment, but I wouldn't use HIFU as first line. And at least I'm very consoled by the fact that I can be confident that it's most likely almost not going to aggravate it. And I can do this treatment for a melasma patient, because melasma patients also have that psychological loss of confidence. A lot of them are depressed. It really affects their lifestyle and who they are. Not being able to do an excellent treatment like HIFU that can really help their general skin health and tissue tightening is even more depressing, is even more disappointing to them. So being able to confidently say, let's do this. Of course, there's a small possibility, but very low risk. You can do this, and it's might not gonna help your melasma, but there are other room for improvement in your face and your neck that this treatment can provide for you. I think that's a very big advantage, a big tool that we have for melasma patients.
Okay. Fifth question, may I ask how you'll treat the neckline effectively and how you'll combine the cartridges? And also, what are the settings?
Yeah, I mentioned this in the lecture already. I don't use 3.0 at all on the forehead. 2.0 millimeter dot, 2 millimeter dot is my main. Additionally, 1.5 millimeter dot on top of that, KIV.
Okay. Sixth question, please let us know your forehead treatment. Linear
금방 했어요.
3.
금방 했어요.
Okay, we'll skip that then.
아니, 금방 했어. I just mentioned that. I just answered that.
Okay.
I don't use 3.0 on the forehead.
Perfect. For seventh question, dot 3.0 or linear 2.0 can also use around periorbiter for eye bags and eye lift.
Okay, it depends on how you define periorbital. Again, if we're on top of the orbital rim, if we're on bone, the patient has very thick tissue, a lot of fat, then maybe the dot 3.0. In practical practice, do I use the dot 3.0 dot a lot on the periorbital? No. And I told you I don't use it on the forehead again. My main go-to is a 2 millimeter dot. And that is because we can get into these areas side by side because of the shape of the 2.2 millimeter like that. If you're using, a linear like this, this is the only area that you're going to have the energy coming out. Well, this area is wasted, but still you can't move it closer to the nose because of the length of the cartridge. So yeah, whether it's the linear 2.0 or the dot 3.0, I don't think it's very practical around the eye. When we're talking about eye lift, I guess implying upper eyelid lift. And there's a lot of different factors related to that, as we know. It's not just the upper eyelid, but also the tissue around the orbit. And that's why, of course, things that we can address with HIFU, 2.0 dot a lot around the periorbital, but still I stay on the bone. So the upper eyelid is not an area I treat with HIFU. I don't recommend that either. I use monopolar RF with the corneal shield to the upper eyelid. For maybe the temple areas, yeah, the dot 3.0 I do use, unless they're very, very thin skin or very thin subcutaneous layer, I do use the 3.0 dot around this area. And of course, I've been using on the cheek, so I've been using it around this area anyways. But when it comes to the infraorbital or the supraorbital, I do not use the 3 mm.
Okay, thank you. With the linear cartridge, what sort of percentage of fat reduction can we expect?
I would like to know that too. I explained earlier, there are very little published articles on linear cartridge. That's something that we will have to look forward to in the future, and that we will have to, that's our responsibility as users to do ourselves. But there's no published or documented, I think, objective data on the percentage of fat reduction. There's just so many factors in there. Again, not only the fat, but also the laxity of the fibrous tissue that is in the subcutaneous layer. I told you it's not just fat. There's also a lot of fibrous tissue around the fat with that laxity causing it to bulge. So it's not just a matter of dissolving the fat, but also tightening the fibrous tissue. And that's what we see. But what we see from the outside is just the bulge. So when we talk about clinical improvement of maybe jowls or double chin, that's something, I think that can be subjective, and it really depends on a lot of different factors. It can't really put a number to that. I'm sorry.
Okay. With higher energy, can we reduce treatment lines?
Okay, I would like to ask you, why do you want to reduce the treatment lines? We have to think about our motives too when we're treating patients. Of course, we all have the patient's interest in mind. And when we're looking at the patient and we see the patient, we want good results, right? But we also need safe results. We know that as we increase the energy, there is higher risk of side effects, but we also want to have good results. As I mentioned before, if we have adequate time, and say we had adequate time and we could do more lines at a lower energy and it gives same results, which one would we choose? So there, like I mentioned before, there was that paper about talking about lower energy but multiple passes compared to high energy and less passes. So with higher energy, can we reduce treatment lines? Maybe, but you have to be careful and find the balance. Be careful of side effects and complications. And I would recommend, in my personal experience, is maybe a little bit lower energy. I'm not going to max out the energy, maybe middle to moderate energy, but more passes and more lines would be my personal recommendation. And that would be safer and more comfortable for the patient. You go higher energy, most likely patient's going to be more painful. There are many patients who have done a treatment and have had so much pain. I'm sure you've had these patients, they say, I'm never going to do that again. It sort of blocks that option out. And I don't want to block this option out for them. This is an excellent treatment. I want them to be able to come back to this treatment repeatedly. But the experience also has to be acceptable. So they can endure longer time in the chair than excruciating pain, but getting out in 10 minutes. So that would be my advice. That would be my approach.
All right, this is the last question. How would you treat sunken cheek for lifting effect? Apply more shots of 4.5 or dot 3.0. How can we avoid fat loss during HIFU treatment with dot 4.5? Also, does dot 3.0 also have lifting effects?
Okay, I think the first question is meaning, how can we still have skin tightening in patients who have sunken cheeks? Maybe that might be the question. And again, there's a difference between lifting and tightening. We need to be sure of that. Do I think HIFU provides a lot of lifting, strong lifting effects like threads or facelift? No. Again, my opinion is still that HIFU is more for tissue tightening and firming. In sunken cheek patients, like I showed you earlier, can we still do HIFU? Yes, definitely. We can, and I have, and I'm sure you have, but we just have to be a bit more cautious about the depths or the cartridges that we use. Again, it has to be case by case. In general, I would avoid using the 4.5 in those sunken areas. The whole face and neck might not be so sunken, but in those areas, yeah, maybe I'll avoid using the 4.5 in that area. 3.0 dot, I would still use, but not at a very high fluence. Again, multiple passes with a low fluence might be more advisable, but still, yeah, definitely, we do have to get down to the deeper level. And just, if the deepest is 2.0, I think that's too superficial. So even if the patient has sunken cheek, still, I'll use a little bit of 3.0 millimeter for that patient. How can we avoid fat loss during HIFU treatment with dot 4.5? Just like what I explained, first of all, is avoid using the dot 4.5 in areas that you want to avoid fat loss and that you deem are very risky. Using lower fluence, not reducing the interval below 1.5 millimeter. Don't stack, so make sure you don't stack. You can space out the lines a bit wider in those areas that are sunken. Also, does dot 3.0 have lifting effects? Again, are we talking about lifting or tightening? I'm assuming you're talking about tightening, firming, which is the HIFU strong point. Of course, I think that definitely dot 3.0 is, like I said, one of the workhorses that I use, one of the most shots that I use during the treatment. That has tightening, and if we have to get to that layer, I think it's really that adequate cartridge that gets to the layer where the patients feel effect. So it's sort of, the mainstay, I think the center of the treatment is the DOT 3.0.
All right. Thank you very much, Dr. Kim. It was super helpful for all of us. And it was really, really good time. I guess it meant a lot for all of us, and everyone, like almost everyone, stayed for this whole
Thank you
Q&A
so
session as
much.
well. I can
Thank
see
you.
that.
I want to say
Yeah.
thank you to everyone who
Yeah.
stayed to the end. I know it was very long, but I've done quite a few lectures on HIFU before, but I always rush and talk so fast. I didn't even feel that the meaning was really came across. So today, I really tried my best to convey the knowledge and experience that I have and share with you. So I hope that it helped you, and it will help you in the future, in your practice and how we approach aesthetic medicine and skin health and skin quality. Again, HIFU is really, again, it's not a matter of do we or do we not need a HIFU. We need a HIFU. Everyone needs HIFU. It's just, I guess, what type of HIFU and how we're going to use a HIFU. It's not like, okay, how am I going to use my HIFU to contour? Yeah, we can do that with this machine, but there's so much more that this can provide. And are we telling our patients that this can provide so much more for you? So I really hope it was beneficial in some way to you guys. And, like I said before, send me a DM, let me know what you thought, give me your feedback. I want to improve myself as a person, as a lecturer, and as a doctor. So please DM me or write me an email. I'd love to keep in contact with you and to discuss more about how to utilize HIFU, the Ultrasound Q Plus more. I'm also learning and I want to learn from you. So please share with me your knowledge and your experience. And thank you, Jesus, for being patient with me and for giving me this opportunity.
Thank you very much. If everything's okay, everyone's okay, we would like to put an end to this section. And we really hope to meet you again, Dr. Kim,
Me
for
too.
another chance.
Yeah, I hope we can meet in person someday soon.
Sure, definitely. We really hope so. Right. Thank you very much for everything today, Dr. Kim.
Thank you very much. Thank you.
Thank you.
Okay, bye.
Bye-bye.